All right, so we're now into week 10 of the course, and this week we pick up the topic of healthcare policy in the U.S. And so we're going to be looking primarily at Medicare, Medicaid, and healthcare reform, referring to the Affordable Care Act that was implemented back in 2010. So here's a quick outline behind me of what I want to cover this week. And so first, I'll just provide a basic introduction in terms of the health insurance industry in the U.S. So there are different outcomes that we can examine in this area, in the area of healthcare policy. We could be looking at public health. We could be looking at issues of access to healthcare. That is, are people getting the much needed care that they need in terms of overnight hospital stays and doctor visits? We're not so much looking at access to care, but mostly about access to health insurance. And so I just want to make that clear before we dive in here. So I'll note some of the disparities or inequities and some of the inadequacies in the current system. And when I say the current system, of course, I'm referring to the health insurance industry. And then we'll look at the health care system and really the health insurance system, both public and private, with more emphasis, of course, on the public system, namely Medicare, Medicaid. And the last part of this lecture is just one of the many issues in this area, and that's with respect to cost and quality and the balancing of the two that we're attempting. And so this is just diving in to this section here. And so we have a new healthcare system. We have a new healthcare system that went into place as of 2010. So President Obama signed into law the Patient Protection Affordable Care Act in March of 2010. And so the legislation itself is about, the initial legislation was 1,200 pages. Today, I've heard insiders tell me that the legislation is now upwards of 2,000 pages. So it's a substantial piece of legislation with profound effects, not only in terms of an impact on doctors and nurses and such, but also it affects consumers. And even if you don't really care about access to health insurance or health care for that matter, certainly in the way of the taxes that we pay, you're certainly going to be affected with the new law. This is just a quick note on why we should care as future social work professionals. And so this type of slide is often like preaching to the choir, I suppose, but certainly many social workers will go on to work in healthcare settings. And so this material is in fact important to your future career as social workers. And even if you're not planning to work in the healthcare field, certainly, as I was alluding to before, in the way of the taxes that we pay, certainly we're all affected in some way. All right, so here I'm just looking at the current system. And once again, I want to emphasize that the main issue here is in assessing the current system with respect to access to insurance, right? So I'm not talking about access to care, I'm not talking about public health, but if we're assessing the current system in terms of access to health insurance, and we're using these two criteria here that I named, that we're talking about adequacy and equity, or the inadequacy or the inequity in the current system. I'm just making a quick case here in terms of the inadequacy of the system, and to do so, I'm looking at the CDC, or the Center for Disease Control, and their surveys and what the surveys are revealing in the way of uninsurance in the U.S. And their estimate as of early 2013 was at 14.8%. You can see the estimate up here. 14.8% of the U.S. population estimated to be without health insurance coverage for the whole year. If we're examining those without health insurance coverage for at least part of the year, that estimate is a bit higher at 18.5%. And then those without coverage, without persistent coverage, is still relatively high at 11.1%, according to the CDC. Now, assessing health insurance access in terms of inequities or disparities in the current system, I'm noting here some of the age, race, income, and education disparities. So first, in the way of age, it would make sense to note that there are disparities, most notably in the way of the working age population not being covered historically, and that's because of the way that our public system operates. That is, the program of last resort that we've had historically, that's Medicaid. Medicaid historically has not offered any sort of coverage to the working age population, those between 18 and 64, and so it would stand, of course, it's logical to assume that that particular age demographic is most likely to be without health insurance relative to kids and the elderly. And so you can see here very quickly in terms of the elderly, and we do a great job. Only about a little over 1% of elderly are without health insurance coverage. And so we see these age disparities. We notice race, ethnicity, income, education disparities as well. So in terms of race, ethnicity, so Hispanics historically have been upwards of 3 times as likely to be without health insurance coverage relative to non-Hispanic whites and also blacks. That ratio is starting to diminish with the new health care system. And I'll show you some of the numbers briefly here. And then there are income disparities. Certainly those who are living in poverty are much more likely, almost three times as likely to be without health insurance coverage relative to those who are not in poverty. And then education disparities, those without a high school education, much more likely to be without health insurance coverage relative to those with high school education. So here are the numbers. What I just described to you in narrative form, these are the actual estimates. These are not the CDC estimates, but these are actually the census. This is the census data. You can see the uninsurance rate for kids, so those under 18, 7.3%, and you can see that the working age population, right, 19 to 64, is between 2 and 3 times as likely to be without health insurance coverage relative to kids. And then I noted the uninsurance rate for the elderly at 1.6%. We have certain race ethnicity disparities that, as I pointed out, and most notably Hispanics of any ethnicity, 24.3% relative to this 9.8% for white not Hispanic. And there's another distinction here between native-born populations and foreign-born populations. This can further be distinguished. The foreign-born population can further be distinguished in terms of citizens and non-citizens, and it's anywhere between 2 and 3 times as likely to be without health insurance coverage relative to the native-born population, according to the most recent census data. Where we were looking at rates before, this is more an issue of composition, so looking at the different types of coverage that people have. So most people in the US, according to census data, have private health insurance, whether it's employment-based or whether they went out in the market and they purchased it themselves. So 64%, upwards of 64% have private health insurance coverage. You can see the coverage, our public system, and the extent of coverage with our public system. Medicare is 15.6%, Medicaid 17.3%, and then our uninsurance rate, according to census data, is at 13.4%. I just reported 14.8% uninsurance rate based on the CDC data, but this is the CDC data come from early 2013. This is by the end of 2013. We were at 13.4% according to the census, the most recent census figures. All right, so this is a bit of a transition here where we're looking at our public system. I want to look first at the public system. We'll take a brief look at the private system, but first in terms of Medicare. So the first thing I want to say about Medicare versus Medicaid, if someone were to ask you for at least one distinction between Medicare and Medicaid, I hope we can at least say that Medicare is in fact social insurance and Medicaid is public assistance. And so all the things that we know about social insurance and public assistance will apply in the context of this discussion about Medicare and Medicaid. Okay? And so as a condition to eligibility, you have to contribute over your lifetime. Right? You have to put something into social insurance programs to qualify. And so assuming that you've made the required contributions, the 10 years of work history that we find under Social Security, there are 3 different pathways into Medicare eligibility. One is based on age. If you're 65 and older, you're potentially eligible. If you've been receiving SSDI, or Social Security Disability Insurance benefits, for at least 2 years, you can also qualify for Medicare. And then if you have end-stage kidney failure or renal disease, you can also qualify regardless of age. That's just any age. You can qualify on that, based on that category. And then here I'm noting the benefit structure. There are different types of benefits that are offered under our Medicare program. And so there are 4 major components here. There's parts A through D. Part A will cover your overnight hospital stays, your inpatient services. It will also cover some transitional care, so some skilled nursing, some home-based care, and then also hospice care. So if you, that's sort of a nice little niche. On a side note, that's sort of a nice little niche for social workers. So those who have been diagnosed with having less than 6 months to live, sometimes social workers will go in and counsel those families. That's what we mean by hospice care. And so the larger point was that Part A covers hospice services as well. And so as we go through this, just think about as we go through the benefit structures of these different programs, think about the potential premiums that people would have to pay, the deductibles that people would have to pay, and also the co-pays and the co-insurance amounts, meaning the actual amounts that you would have to pay in conjunction with the government, or the actual percentages that you would have to pay in conjunction with the government. That's what we mean by co-pays and co-insurance. There are different co-pays and co-insurance amounts for all these different components. And so note first that Medicare Part A is not optional, right? So your FICA legislation, right, that we talked about, the Federal Insurance Contributions Act, and how it takes out 1.45% of your earnings for Medicare purposes. So your tax, your 1.45% Medicare tax, goes towards paying for overnight hospital stays of current beneficiaries. Okay, so it's also a pay-as-you-go system. And then in terms of the premium, there is no premium. You don't pay a monthly amount. You've made that contribution over your lifetime. That's what you get when you retire. Right? You've paid into it over your lifetime, so that contribution would render you eligible for Part A assistance. And then in terms of the deductible, you have to pay the first night stay, and that cost for 2014 happens to be here $1,216 for 2014, and then that amount increases a bit for 2015. And then notice here the co-payment structure. So of course you pay the first night, and then the second night all the way to day 60. Medicare Part A will cover that cost. And then from day 61 to day 90, you have to pay approximately 25 to 33, I can't remember the exact amount, but it's about 25 to 33%. And then from day 91 up to what's called a lifetime reserve, you get 60 days of a lifetime reserve. So you're going to end up paying about 66% of that lifetime reserve cost. All right, so Part B. Part B is not automatic, right? Part A, based on your FICA contribution, you automatically are going to receive Part A, but you don't automatically receive Part B. And so if you receive Medicare Part A, you have to pay an additional premium to qualify for Part B. And that premium amount is noted here. And so that's $104.90 for 2014 and 15. You have to pay that monthly premium. And then you have to pay a deductible. You have to pay a deductible in the amount of $147. You pay the first $147, and Medicare will kick in and pay 80%. 80%, Medicare Part B will pay 80% of all remaining costs for doctor visits, x-rays, for lab tests, outpatient services. In other words, Medicare Part B will cover. Part C is Medicare, is what's called Medicare Advantage. And so this is traditionally supposed to fill gaps in your coverage. So anything that's not covered by Medicare Part A or Part B is covered by Part C. This is where you have a bunch of private health insurance plans that offer their services through the Medicare Part C, through the Medicare website, essentially. And you go and you would go to the Medicare website and search out plans that meet your needs. That's Part C, and so I've left out that discussion. That's mostly a private system. And then you have Part D, which is your prescription drug benefit, and that's the most recent addition to the Medicare program. So just a quick note about the Medicare Part D component. The major policy issue here that most people talk about is in the way of the donut hole. The donut hole, basically what that says is once your out-of-pocket expenses reach a certain amount, so that amount changes every year, but once it reaches $2,850, right? So if you have out-of-pocket spending in the amount of $2,850, that's the point at which you have to start paying a certain percentage of that cost. And so I note the percentages here, depending on whether you're paying for prescription drugs or brand name drugs or generic drugs. So there's different co-insurance amounts here, 47.5% for brand name drugs, 72% for generic drugs. And then if you have catastrophic needs, if your out-of-pocket expenses on your prescription drugs reaches a certain amount, and that amount changes every year, but once it reaches $4,550, then Medicare, once again, Medicare Part D kicks in and will cover most of that cost. 95% of the costs for catastrophic needs. And then just a quick note about what seniors on Medicaid typically pay. So barely nothing, right? $2 to $5 is a typical range per month for the prescription drugs. This is for Medicaid, which we'll talk about in a second here. This is just a quick note on healthcare reform, what the Affordable Care Act actually did in the way of the Medicare program. So first off, there was a temporary reinsurance program for persons who were not covered. So what I'm referring to here is people who may receive Social Security benefits. So you can receive Social Security benefits as early as age 62, but that, of course, leaves a 3-year gap in terms of when you can actually receive Medicare coverage. And so this was a temporary program for persons who were in that range, 62 to 65 age range. It was initially offered, but it's no longer offered under the Affordable Care Act because of the cost of administering the program. But there's another change, major change that went into effect with the new healthcare legislation, and that's a Medicare tax hike of 0.9%, almost 1%, for persons who make more than $200,000. Most people pay 1.45%, right? So FICA mandates a 1.45% contribution typically for most workers. But if you make more than $200,000, you pay an extra 0.9%, so it comes out to 2.35% in the way of a Medicare tax. And I note here the estimated revenue that would generate over the first, I believe, over the first 10 years. All right, now we're switching gears to Medicaid, so sort of the cousin to the Medicare program. So Medicare is a social insurance program. Medicaid is a public assistance program, meaning that you have to be poor, of course, to receive benefits. In terms of eligibility, this was once a very fragmented structure where every state imposed a different eligibility requirement depending on what category you qualified for. So if you were a pregnant woman, or if you were a child under 18, if you were an elderly person, if you were a person with a disability, there were all different sorts of eligibility requirements that was fragmented from state to state. And so what the Affordable Care Act accomplished was in the way of establishing uniform eligibility requirements. And now, basically, if you're anyone with income up to 133% of poverty, you're now eligible. Now notice, I didn't say anything about the working age population. The working age population was categorically ineligible for Medicaid assistance before 2014, but now anyone with, like I said, income up to 133% of poverty is in fact eligible for Medicaid assistance. I'm just showing here the makeup of Medicaid enrollees. So kids, right, you can see that children comprise at least almost half of all Medicaid enrollees. But in terms of costs, you can see that persons with disabilities and seniors, they're much more expensive to cover in the way of Medicaid benefits. Okay, so typically seniors, persons with disabilities, they only make up 25%. The major point is that they make up 25% of enrollees, but they account for upwards of 75% of costs, total Medicaid costs. And then finally, a quick note in terms of the financing for Medicaid programs. And that's a formula here, 50 to 80%. The federal government will contribute between 50 to 80% of the costs of administering the state Medicaid program. And that depends on state wealth. Well, where the state is wealthier, the federal contribution is closer to 50%. Where the state is poorer, the federal contribution is closer to 80%, is the basic formula that's used to finance the state Medicaid plans. You see here some of the services, the Medicaid services that must be offered. There are federally mandated services. There are some core services that must be offered, including your overnight hospital stays, your doctor visits, your lab testing and such. Nursing home stays. Your nursing home stays must be covered under the state Medicaid plans. Pregnancy services are also mandated under the federal legislation. But then there are a bunch of optional services that states may pick and choose from. And so things like dental and eyeglass and such, eyeglass care, those are optional services that states may or may not choose to offer to their Medicaid beneficiaries. So if we're looking back in time and thinking about some of the changes that were implemented with the Affordable Care Act, so I had noted before the eligibility provision, right? We made a uniform eligibility threshold across all the different states, a major development in the way of Medicaid reform. And then, of course, we have a benefit floor now. We have sort of the same benefits, the same mandated benefits across state lines as well. All right, just a quick note on this program called CHIP, or the Children's Health Insurance Program. Basically, the way that it operates is that it's a non-entitlement program, meaning that states don't have to offer it if they don't want to. If they have enough revenue in their state treasury, they can offer supplemental benefits to kids who may not have been covered under their state Medicaid plans. Maybe their income was too high, it was above 133%. What the CHIP program will do is offer coverage up to 200% of poverty. for certain families who don't qualify under their state Medicaid plans. That's the gist here. And that's what the Affordable Care Act implemented. All right, finally in this section, we're going to talk about private insurance. So I know there's a lot here in this lecture. It's a very dense area, this healthcare policy, but finally we're talking about the marketplace, right? So we're talking about private insurance. If you don't have Medicare coverage, if you're not a person with disability, if you're not a senior, if you don't have Medicaid coverage, if you're not poor, and if you don't have employment-based coverage, then you have the marketplace option, right? You have this marketplace option, also referred to as the health insurance exchange. And so basically, the big policy issue here in terms of the marketplace is that you must find some coverage, right? So basically, the federal government, when they passed the Affordable Care Act, was saying that you have to contribute into the system, into this new, what's called the managed competition framework, or managed competition system, where it's not really entirely public, it's not entirely private, but the government is overseeing a bunch of private insurance companies that are competing for your services, right? That are offering their plans, their private plans, on their website. And so that's what we call a managed competition framework. And one of the primary issues here is this individual mandate, or more euphemistically phrased as the individual responsibility payment, where if you don't get coverage, right, if you don't have some form of insurance coverage, there is a tax penalty. And so you can see what the tax penalty is. This was different. It was much more lenient last year. But for this year, if you don't enroll, if you don't have a plan by 2015, you can see what the penalties will be. It's $325 per adult in your household, and then $162.50 per child in your household, or 2% of household income, of your total household income, whichever is higher, right? So whichever is higher, that's the penalty that you'll pay. And you can see how steep the penalty is for 2016. It's $695 per person. Doesn't distinguish between whether you have adults or kids. It's just per capita, meaning per person in your household, or 2.5%, whichever is higher. And notice I provide here the enrollment periods. So on a practical level, you should go to the website in Illinois. It's called Get Covered Illinois. And so if you go to that website, November 15th is the start date for that open enrollment period, and that enrollment closes in February of 2015. Now, just a little bit in the way of the different benefits or the plans that are offered. So there are basically 5 categories of plans that differ in terms of the premiums that one has to pay, in terms of the deductibles that people have to pay, and also the co-pays and the co-insurance, the amounts there. And so from bronze all the way to catastrophic. Typically, the lower tiered plans, the bronze plans, will be cheaper in the way of the monthly premiums, but then of course your co-pays and your co-insurance percentages, those percentages will be greater. And so it's really a balancing of all the different factors there. And you can see all the different factors that go into the pricing of these private plans, where you live, whether or not you smoke, your age, your family situation, all these things will impact the pricing that's offered for your plan. The major accomplishment I note in bullet point 4 here is that your out-of-pocket expenses, presumably with these plans, have been capped, right? So for 2014, the maximum out-of-pocket expenses that an individual should incur, is $6,350. And then for a family plan, your total out-of-pocket spending should be capped at $12,700 for any one of these plans. And of course, you guys have all heard about how pre-existing conditions were never covered before. And so that's been a change with the Affordable Care Act. And also in the way of coverage for dependents, so you're covered under your parents' private plan until age 26. Those are major accomplishments as well in terms of the Affordable Care Act. Last note here in this first section of the lecture, and that's regarding the tax treatment. So all these private plans that we've just talked about, right? All these private plans, so these private plans are not subject to tax, so you don't have to pay tax necessarily on the benefits that you're offering. It's only if you don't get coverage that you pay a tax penalty, but we're talking about here the tax treatment of your health insurance benefits. Since you don't pay tax on your health insurance benefits, we're just assessing whether that might be more favorable for the low-income worker relative to the high-income worker. And certainly the fact that that your health insurance benefits escape federal tax liability is more beneficial for the higher income worker, who's typically subject to higher marginal tax rates than the low-income worker. And so we characterize the basic structure there as being regressive in nature, that is much more favorable for the higher income worker relative to the lower income worker. All right, so in the next section, I'll talk about one of the major policy concerns, and that's this balancing between the cost and the quality. We're constantly trying to minimize or control costs in the way of administering our health insurance in our health care to the U.S. population. But of course, you get what you pay for often, right? If we cut costs, does that impact quality? That's the last issue that we'll discuss in this lecture.